Thank you all for joining us today. My name is Christina DeFrancisco, and I am the Director of Communications and Development for the Ear Research Foundation. Welcome to Hearing Education Series presented by the Ear Research Foundation. Today's webinar topic is hyperacusis or noise intolerance. We are joined by Dr. Herbert Silverstein, President and founder of the Ear Research Foundation. Dr. Silverstein is a world-recognized expert in hyperacusis and has developed a minor surgical procedure to reduce hyperacusis. Before turning the webinar over to Dr. Silverstein, please be sure to keep yourself on mute during the presentation. If you have questions, please submit them via the chat below. Questions will be answered at the conclusion of this presentation. Again, I would like to thank you all for joining. For more information about our organization and how you could help our mission of research, education, and community care to ensure we can continue to provide educational webinars to all, please visit earrf.org. Now here's Dr. Silverstein.
Thank you, Christina. So today we're going to talk about hyperacusis. This is a subject that I became aware of actually not too many years ago. Actually, 2009 was the first patient that I saw with hyperacusis. And we'll go through the story. The four types are hyperacusis, recruitment, misophonia, and phonophobia. And we'll talk about each one of these things. So hyperacusis is a condition where a person cannot tolerate normal sounds. They become very anxious and avoid places like movies, restaurants, and sporting events. It often affects their quality of life, and many of them become recluse and don't want to get out and talk to anybody. And their lives are actually pretty miserable. Supposedly, this affects 6 to 17% of the population. This can occur when there is normal hearing or actually a sensorineural hearing loss. And the way we determine whether you have hyperacusis or not is to test your uncomfortable loudness level. And most of the patients are below 90 dB. Normal is between 90 and 100. Most normal people can tolerate that much sound. Tinnitus or ringing in the ear is associated with about 40% of the patients. The patients treat themselves with earplugs. There's tinnitus retraining therapy, TRT, cognitive therapy, long-term treatment usually is required, and the results are variable and may not be effective. Now, recruitment is the second type of hypersensitivity, and this occurs mostly in patients with Meniere's disease who have a hearing loss. And what happens when the sound gets to a certain level of their hearing loss, they get a sudden increase in threshold and they hear the sound very loudly. And this is seen, again, in patients with increased pressure in the inner ear from Meniere's disease. The treatment is the same as for hyperacusis. The third type of hypersensitivity is hypersensitivity hearing of certain specific frequencies. This is commonly seen in autistic children, and the treatment is auditory integrative therapy, or AIT. Phonophobia is a fear of sound. Misophonia is a dislike of sound. You can remember when you were a child and you were listening to the chalk scratching on the chalkboard, how unpleasant that sound was. Usually the LDLs or loudness discomfort level is normal, and patients may need psychotherapy to get over this. So what is the cause of hyperacusis? Most of the patients, or half of them, the cause is unknown. Head injury seems to be very common, or cochlear trauma due to sound blast in the ear. Superior canal dehiscence which is a decrease of bone over one of the semicircular canals, seems to be associated with hyperacusis. Perilymph fistula, which is a leakage of fluids from the inner ear, can cause hyperacusis, and adverse reaction to certain medications. And recently, as we'll show you on our videos, we found hypermobility of the stapes, or the third bone of hearing, which has been a new finding in the last 3 or 4 years. So the possible mechanisms of hyperacusis is impaired neuroplasticity in noise suppression, our hypersensitivity of the cochlea to sound, our hypermobility of the stapes. So looking at the literature, there actually was only one paper when we first started doing this, which showed a patient that had hyperacusis with the superior canal fistula. And when she had surgery to close the windows, the round and oval window, the hyperacusis went away. There's been no previous literature reporting round and oval window closure reinforcement for hyperacusis. So the first patient, WS, was seen in 2009. He was involved with a loud blast from an explosion, and his one ear was traumatized with a tear of his tympanic membrane, and the left ear, he developed noise intolerance. It was driving him crazy, and he didn't know what to do about it. And actually, I didn't either. But I asked him if I said, we can try to put some tissue in your ear that would dampen the little bones of hearing that may make the symptoms less. And in this patient was willing to undertake an experimental procedure where we took some tissue and placed it on the round and oval windows, and he was significantly improved. So this shows you the tissue that's placed all around the stapes and the round window, and to decrease the sound pressure going into the inner ear. And on this one, you can see the tissue over the stapes here. The second patient was seen 5 years later, actually, in 2014. This patient had hyperacusis for years. It impacted her quality of life, and she had to avoid noisy places. And she asked to have something done, and I told her about the procedure that we had done before, and she agreed to go under the procedure, and the right ear was operated first. And after that surgery, she was asked to have the left ear be done because she was so happy with the result. So this is how we do the procedure. We take a little bit of tissue from above the ear. It's called fascia tissue. It's overlying the muscle. And we use a little biopsy punch and make little round circles of the tissue so that we can place that in the ear. Get this. So I wanted to show you this hypermobility of the stapes. Here you can see us showing the hypermobility of the stapes. We're touching the incus bone and the stapes. You can see the stapes is more mobile and has more motion than normal. We're going to talk and show you the procedure from the beginning. Now we're raising a tympanomeatal flap and elevating the skin and the eardrum so we can look into the middle ear. This is the left ear. We can see the round window down on the left and the stapes on the right. Now we're using the little dermatome punch to make the circles of temporalis fascia that we're going to place around the stapes and the round window. We use a 2 millimeter punch and a 4 millimeter punch. Several pieces of tissue are placed on the round window, and then a small piece of gel foam is placed to hold the tissue in place there. So the round window is now being reinforced. Next, we'll be taking tissue, a small 2 millimeter piece, and placing the first piece on the stapes foot plate. We usually use 10 pieces of tissue, packing it all around the stapes, crura, and the foot plate of the stapes to try to decrease the mobility of the stapes. Now we're putting the drum back in place. This will show the procedure. So we're showing how the little stapes bone, this is the incus bone that I'm touching with an instrument, and that's the stapes bone that's being moved around. The stapes should not be moving that easily. And the chordotympany nerve, or the nerve of taste, is running over the area. So we've used electrical stimulation that'll show that the movement of the stapes is very loose. It shows the stapes contracting there. You can see it going back and forth. So you'll see what happens after we put tissue around the stapes and oval window. Now you can see that the stapes is moving a lot less, and the patient's symptoms were markedly improved by doing this procedure. Now we're stimulating again to show you that there's less movement of the stapes through the electrical stimulation. So we did a prospective study of 20 adult patients, age 18 or older. And this was an IRB approved procedure and study. And what we did was we measured the patient's hearing. We did the LDL test, their loudness discomfort, did a CT scan of the temporal bones to be sure there was no fistula of the superior canal. And they had to fill out a Hyperacusis questionnaire, a tinnitus handicap inventory, and a hospital anxiety and depression scale. So we measured the patients before surgery and at 4, 24, and 52 weeks. So 6 months result, 10 patients or 14 years, 7 out of 10 patients reported subjective improvement in noisy situations. 1 patient with misophonia was not improved, and 2 patients with very low ULLs of 50 and 60 dB were not improved. But there was noticeable improvement in the opposite ear being operated. And patients with bilateral hyperacusis asked for the second ear to be done when it was severe. And some patients did not need the surgery on the second ear. And there was no subjective hearing loss from putting the tissue on the little bones of hearing. So we went back and looked at all our patients in 2022. We called 70 patients and 81 ears. 31 patients responded to our survey, and 29 out of the 31 would recommend the surgery. And the average preoperative severity from 1 to 10 was 9.3. And this was decreased in severity to 4.7. So in conclusion, there's marked improvement after the first ear surgery. The unoperated ear improves. It may not need a second ear surgery, but the tinnitus was unchanged in any of these patients. And this was a picture of the first paper that we wrote. We've written 4 papers that are available on Google if you want to check those out. And on our website, we again show the surgical procedure and answer any questions. And there's some testimonials on our website. So we'll open it up to questions at this time.
Okay. The first question is, why do sounds become more and more loud by day?
That's a good question. I don't have an answer to that one.
Okay. The next is your procedure is relatively new and very uncommon. Are you training a new generation of surgeons to perform this and master this technique?
Yes, we have a training program here where we've trained 49 young doctors in ear surgery, and all of them have been trained to do this procedure, and it's being done around the country.
Can you comment on collaborative aspects you may have with other surgeons around the world who perform this?
We have not had any collaborative situations with any other surgeons at this time.
The next question is, how much room do you believe there may be for improving the effectiveness and outcome?
Say that again.
How much room do you believe there may be for improving the effectiveness and outcome?
Well, when we first started doing this procedure, we put very little tissue around the stapes because we thought the round window was the main problem. And after several years, we found out that when we found that the stapes was hypermobile, we put more tissue around the stapes. So the question is whether if you put even more tissue than we're putting in now, which seems to be quite a bit, will that help the results? And we don't know that since we haven't done any further studies on that. We have one patient out of all these patients that we're going to redo and actually add more tissue. This patient had a good result for 2 years. And after a COVID injection, the patient noticed that her symptoms of hyperacusis returned. And so we're going to re-operate that one patient and put more tissue in.
Are there any trained surgeons outside of the U.S. That you know?
No, but this is not brain surgery. This is not difficult surgery. And this is not a difficult procedure to do. It's a very minor operation. And most ear surgeons are able to do this, can do this surgery.
Can this procedure be done on someone with a cochlear implant?
Oh, very interesting question. I don't think this would work in a cochlear implant because the sound is being transmitted by the prosthesis into the inner ear, and the ossicular chain is not being involved at all with the hearing. So this would not be indicated for somebody with a cochlear implant.
Okay, the next question is, does this surgery work for pain hyperacusis caused by medication reactions?
Well, that's a great question, and I forgot to mention that. For some reason, some patients have pain with the hyperacusis, and almost every patient has been relieved of the pain by doing this procedure. And I'm not sure exactly what causes the pain and why it's better, but that's what the patients tell me.
Have you found that patients with hypermobile stapes tend to have hypermobility generally as well, or is it usually isolated to the stapes?
It's usually isolated to the stapes, and it's usually related to some trauma or head injury or sound blast in the ear that would cause the ossicles to be jarred around by the trauma, or sometimes it just occurs without knowing or having anything that causes it.
How long should a person have hyperacusis before they consider having this surgery?
I think usually we would wait about a year, but the indications for surgery are how much it's bothering you. If wearing earplugs or noise canceling headphones help, then you don't need the surgery. But if it's bothering you and it's affecting your quality of life, and then it's worth doing the surgery. The surgery is a minor procedure. It's an outpatient procedure. It takes about a half hour, and the patient leaves the hospital the same day. They have packing in their ear to hold the eardrum in place for about a week. And we have patients coming in from Europe, from all over the United States, and they can travel after a week. They stay here for a week after the surgery.
Okay. The next question is someone who's already had the procedure but wants to know if they can do it again on the same year with more tissue.
This is, it may be worth doing it. Like I said, we're doing one patient. It would be worth evaluating the ear and doing a loudness discomfort test and looking at the ear. And I think it can't hurt to put more tissue in.
Are there any treatment options besides surgery to help minimize hyperacusis?
Yeah, there are a number of them that I mentioned. The audiologists do tinnitus retraining therapy, and they do cognitive therapy, and they do other therapies to try to reduce the hypersensitivity to sound. And this usually is a long-lasting therapy, and this is how patients have been treated up to this point without the surgery.
Would this work on a Meniere's patient?
Okay, great question. So the patient with Meniere's probably has recruitment, and recruitment is usually not helped by this procedure because the problem is in the inner ear, not in the little bones of hearing. But we have operated one patient that did have Meniere's disease, and that patient was helped. But they had the hyperacusis that was not like recruitment. They had a constant noise intolerance, and so it was not a recruitment problem with this patient.
The next question is, have you experienced that the COVID vaccine can increase the symptoms of hyperacusis even if it's temporary?
Yes. We've had a lot of unusual reactions from the COVID injection. It's caused tinnitus in some patients, ringing in the ears, and it's caused various other symptoms, and it's caused hyperacusis in some patients. So it's very unpredictable about what the results are from the injection and how permanent or temporary they are.
Would you consider hyperacusis a physical condition?
Good question. I think it can be physical, and it could be a mental condition also, but think that we don't know for sure. All we know that if you dampen the sound, like putting a plug below the eardrum, it does, and dampen the sound waves going in, it seems to help the symptoms.
Is there any correlation between hyperacusis and teeth sensitivity?
And what kind of?
Hyperacusis and teeth sensitivity. Is there any correlation?
No.
Have you come across anyone who has had hyperacusis as a result of long-term loud noise exposure?
Yes.
Can hyperacusis occur due to wax removal through syringing?
No. Now, let me back off on that. So I may have answered that too quickly. So if there was a loud noise in the ear when the ear was irrigated, it may have damaged the ear and caused hyperacusis.
Okay. What can be done to help someone who developed hyperacusis after receiving a cochlear implant?
That's a tough one. I don't have an answer for that.
Okay. Is this procedure able to be done if someone has an acoustic neuroma?
We have not done it on somebody with an acoustic neuroma, so I don't know. Usually patients with acoustic neuromas don't have hyperacusis. And so we've never done one, so I can't give you an answer.
Okay. Can therapeutics such as FX322 that need to permeate the round and oval windows still permeate it after the extra tissues are added?
Probably not. And that's a very good question, because we are involved with that study in a big way. We have the most patients in the country that are involved with that study at the Ear Research Foundation.
The next one is, does age have any role?
Age, I don't think so. We've seen it in teenagers, and we've seen it in old elderly people. We're going to operate on somebody that is in their 80s soon, that developed it from a loud blast in the ear.
How long from having the surgery should somebody wait till they see improvement?
Great question. Very variable. Sometimes it's almost immediate. Sometimes it takes a couple of months. Every patient's a little different. And then I think I should mention, I want to mention something else. As far as the LDL goes, we don't have a good correlation between the LDL and the result. You could have a very hypersensitive ear and have a great result or not a great result. And you could have LDLs that are close to normal and still have a very good result. And we're not really sure about how the LDL relates to the surgical result.
Have you seen hyperacusis caused from COVID?
Yes.
The tissue that you put inside the ear, does that deteriorate over time?
We don't believe that it does, because we did one of the studies we did was a long-term study of these patients that had the surgery. And it seemed like if they had a good result at the beginning, it lasted for years. And so it means that the tissue probably hasn't deteriorated much.
Is this the only surgical method you've used to alleviate hyperacusis and pain?
Yes.
Has this surgery helped any patients with lingering nerve pain in their ears?
No. The pain in the ear that's relieved is related to the sound intensity. But that's almost always relieved for some reason doing the procedure.
If someone with a cochlear implant, would they be able to get the opposite ear, have the surgery on?
Sure.
And would they benefit? Do you believe that they'd benefit from that?
They may.
Okay. Right. Is there any interest in measuring the mobility of the stapes of children on the autism spectrum to see if they would perhaps benefit from the procedure?
That would be a research project that'd be worth undertaking. We've talked about doing the procedure on autistic children, have not done it yet. but we're thinking about doing it. And I don't think that it would matter if the stapes was hypermobile or not in these children. I think we'd just put the tissue in these children to see if it would help them. Because like I said, that the stapes could either be hypermobile or actually normal. And I don't think that changes the results.
Could this be performed on someone who has had a brain shunt?
Yes.
Hi, Dr. Silverstein.
Hi.
It's Andrea Brands. You operated me in March 2019.
Okay.
On my left ear, I have severe hyperacusis. And the operation, unfortunately, didn't give me any progress. My English is not that fantastic, so I hope you understand what I'm saying.
I do.
So I'm really wondering, what else can I do? Because it's really so difficult, my life.
And so you had no result at all?
No, unfortunately not.
Well, I'm not sure that that surgery will help you. Obviously, it didn't help you. And what I mean is, I'm not sure that putting more tissue in your ear would help, but it may be worth redoing it. Try to put more tissue in if you wanted to. The procedures are very, the minor procedure. I don't think you mind the procedure very much, did you?
No, no, not that. That's right.
There wasn't much pain or anything like that related, right?
No, the only thing that I think people have to be aware of is that your tinnitus, the tinnitus can become a little bit worse.
It can become a little worse. Okay.
Yeah, but that eventually disappeared again. So it's at a normal level. But my hyperacusis is really giving me a lot of stress, and I can't go anywhere. So I'm willing to try everything, and I'm looking into doing the operation again, or maybe disabling the bones a bit in my hearing, the stapes, or.
Well, that's a possibility too. So I think it'd be worth evaluating to redo it again. Yeah.
Okay.
Because we don't know the answer to the question until
I know. No, I have another operation possibility, and that's something with the nerves in your brain here. Did you ever hear about that?
Doing what now?
Yeah, I don't understand exactly the operation, but they they stimulate the nerve system with some, and your hyperacusis can become less, or the pain.
Well, I would do it if that's a lot easier than doing surgery. If they can just stimulate something. I don't know.
Well, yeah, that's also surgery, because they have to put some kind of implant under your skin above the ear.
Well, that doesn't sound like a big procedure. I would do that. Try it.
Okay. Thank you. That were my questions.
Okay.
Dr. Silverstein, can you hear me?
Yeah, hello.
Yes, I'm here.
Yes, so I was going to ask. Thank you for the opportunity. So my problem is in one ear, and usually it's not triggered by the loudness. It's usually a prolonged exposure to a particular sound. Say sort of like a loudspeaker around for about 30 minutes wouldn't cause anything, or a loud blast. But say like the air vents or the air conditioner in my office that I'm exposed to for about 8 hours a day causes endless pain and nausea. So I was just wondering if this sort of procedure would help if it's not loud, if it's not a loudness issue, because I know these sounds are not loud, but they are very, very painful.
Where are you located? You sound like
I'm in the United Kingdom.
United Kingdom. Okay. Yeah, I think it'd be worth trying it.
Okay.
If it's bothering you, it's worth it trying it.
Okay.
Because there's nothing else that you can do that I know of.
Thank you.
Dr. Silverstein?
Dr. Silverstein.
Yes.
I guess maybe that's me. We've spoken before. First of all, I just want to say thank you for your innovation and your dedication to this. We need more people like you doing this. I have spoken to you before. You're very helpful. I'd just like to understand from a loudness hyperacusis issue, not even delving into some of the pain complexity. To me, it really seems like an earplug behind the eardrum should be helpful almost in all cases. How, in your opinion, can it end up not being helpful in some cases for this? It just simply fails to dampen the sound in those cases, or what is it?
I don't think there's an answer to that yet, because I don't think we understand. I don't think we can understand why it doesn't work. It could be that it's not dampening the ossicles. That's why I would like to do some revisions and put more tissue in to see if it will work or not. But that would tell us for sure whether it was a mechanical problem or a psychological problem that can't be operated. They can't be helped by surgery.
And just one follow-up, a woman before mentioned addressing the other bones or ossicles or removing them. Any comment on that? Some of us are willing to get aggressive.
Again, I think that's pretty drastic, because that would affect your hearing, and it would decrease the hearing in the ear quite a bit by dislodging the ossicles. Can be done, but I don't think we've ever done that. So.
Okay, thank you.
Dr. Silverstein.
Yes.
May I ask you this? You have a set of preoperative testing.
Right.
Have you stratified the likelihood of benefit, or is it an all or nothing type of thing? Can you predict who should go to surgery or not?
No. You can't. That's what I was telling you, that I was trying to indicate that with the LDL test. We thought that we could determine if you were hypersensitive, very hypersensitive, and your LDLs were like it's 60 or 50, that you would do better or do worse. But we can't, there's no correlation, and there's no way of telling which patients are going to do well or not.
But you still carry out the preoperative screening, these tests?
Yes, we do everything.
For what purpose?
When you're doing research and you're doing something new, you have to do everything the same every time. So we do the same thing on every patient, same procedure, same testing before and after.
So there's no real predictor of results based on the preoperative screening test then?
No, not that I know of.
Right.
I mean, we could go back and look at it. It may be worth doing that.
Yeah.
Now that you mentioned that, you know, we could, we have research fellows here, and we could actually go back. We have all the data, and we could look at it and see if there was a predictor. But so many patients are improved. It's about over 80%, 85% are improved.
Yeah.
That, but I think that's not a bad idea.
It'd be interesting to know, the patients who did not improve, do they show a statistically significant difference in the preoperative screen? I assume you would have picked that up by now.
Yeah, we don't see that. That, you know, it's not obvious. It's certainly not obvious. We'll have to. I like your idea, and I'm going to look into that.
And one other quick thing, I was intrigued by the fact that you said that operation on one ear, the opposite ear may improve.
Yeah, that's fascinating. Yeah, that was something that I didn't believe when the patients were telling me that at first. And I just thought maybe it was, I didn't understand that. And, but this was quite common, that the patients are saying that the opposite ear is improved. So obviously something's happening in the brainstem, that when you cut down the sound waves coming in, it must decrease the effect coming from the other ear. Yeah,
that's fascinating. I mean,
yeah,
that speaks to the pathophysiology of this, which I think you say we really don't know a lot about.
Right.
So, yeah, interesting.
Well, that's what my question was actually about, if I could interject, because I'm single-sided deaf and I have a cochlear implant in one ear, but how do you determine which ear is the one that's sensitive to sound, or is it automatically considered both? Is there data and testing you do that can narrow it down to say this is your problem here with hyperacusis?
Well, we would test the ear that you're hearing in and, see what the result is. I don't
Am I
think
not hearing in both ears now with a cochlear implant? That's
you're hearing in one ear with the cochlear implant, unless you have two cochlear implants.
no, I mean, I have one cochlear implant and one normal ear. So I
Right.
didn't have hyperacusis till after the implant surgery. So I don't know.
Well, I didn't get that picture, but that's a good question.
Well, I'd love to be a guinea pig. I'm throwing it out there for
Well,
anybody who has an
the only way we're going to find out is by trying it.
Doctor, I had a question. I had an acoustic trauma, a very severe one a few months ago, and I've developed a lot of central sensitization, like a lot of acoustic trauma patients do. Would this surgery help with those nervous system symptoms?
What symptoms are they?
Just like excruciating pain in other parts of the body, sensitivity, like to touch and other sensory oversensitivity symptoms, touch and lights and other things.
No, I don't think no,
Okay.
sorry.
Lisa Sabino has a question.
Oh, hi. Yes, thank you very much. I have a question about the stapes. So if your stapes are hypermobile, can they improve with time naturally? But then say you have an acoustic situation, can that get them triggered again? Like I feel like over the years, it gets better, then it gets worse. It gets better and it gets worse. And I don't know if it's the stapes being hypermobile. I'm hoping it is, because then maybe you can help me. Yeah.
I don't think we know the answer to that.
Yeah. Okay. I guess, but you can see when you're doing the surgery, from what I saw there, if they are hypermobile when you're in there, right?
Yes, we actually quantify the movement of the stapes from 1, 2, and 3. 3 is very hypermobile, 2 is sort of moderately, and 1 is normal.
Okay.
So we measure and we take video of the surgery before and after, and so that we can hopefully someday evaluate the movement from the surgery and the results.
Oh,
by
interesting.
looking at the video.
Okay. I have another question about it. If people have had the surgery, I'm in Toronto and I'm involved in music a lot, so I can't. It's affected the quality of my life. Obviously, I'm also a teacher, so it's hard for me to teach in a classroom setting. So after people have had the surgery, do you still recommend that they be careful around loud sounds, even though things have improved? Or is that, you know what I mean? Would you not go to a concert anymore or live sport?
No, absolutely not, because the patients do it themselves. You can't tell them. What they do is they go they test themselves out, they see what they can do, and then they come back and tell me, well, now I can go in a concert and I go in the restaurant, doesn't bother me. And they test themselves out very quickly. Yeah. They want to know the result.
Okay, great. Thank you.
One more thing, I'm sorry, along the lines of the stapes mobility, I may have misunderstood you. Did you say that whether or not there's stapes hypermobility, when you get in there, you still do the surgery and you can get good results even when there's not a demonstrable hypermobility?
That's right. That's exactly right.
That's that's somewhat against the pathophysiology you're thinking about here.
Right. So that the stapes hypermobility only occurs in about half the patients. But and again, that's another thing that we don't understand. Like we don't understand the LDLs. No, the movement of the stapes at surgery does not seem to affect the result.
And you do the same repair with the fascia.
Same fascia, same procedure. Yeah.
That's fascinating. I don't get it.
So there's a lot of questions that we don't understand or don't have an answer for. We just know that it works.
And I'm sorry, one more question. It seems to me that there's not any reason why you shouldn't try it for most people.
So what I tell the patients is this: if it's bothering you and affecting your life, and it's a constant problem, then, and you're in good health, and you don't mind, taking a chance, it's worth the minor procedure to do it, because there's little risk in doing the procedure. And the worst problem usually is that it doesn't work.
Mhm.
And usually if it does work, it lasts. It seems to last for a long time.
Dr. Silverstein.
Can
One
you,
of your
can you address the insurance coverage for this?
Insurance seems to be covering it.
Hello,
one
Dr.
of,
Silverstein.
Yeah.
Dr. Silverstein, can you hear
Yes.
me?
Yes.
Yeah, this is Matt, as a patient of Dr. Jackson's here in San Antonio.
Oh, okay, good.
Yeah, I tried to talk earlier and they wouldn't unmute, but now we can unmute. The question was, just a little background. I had a round oval surgery on both ears. Right ear was my worst, then my left ear several months later. I've had hyperacusis for over a decade. And when I found out about the surgery, I was fortunate to find out that Dr. Jackson does perform it. Long story short, went through surgery, both ears. I've been driving in my vehicle, which has been drastically modified with sound dampening throughout the cab of my truck. It's a plain F-150 pickup. And I had modified the exhaust even to help to reduce the sound waves that were impacting me in the past. I've had to do this twice now with vehicles. First one got wrecked. Bottom line, took a long trip this summer, and I had a setback after the surgery. And I had nausea. And
wait. What was the result of the surgery? Did it help you?
Yes, it helped me. It did help me for about 6 months. But then I took a long trip in my vehicle again, which my vehicle was extremely modified to reduce sound. If you
Right.
rode in it, you would know it's super quiet. But
Right.
there's something got through, some sound wave got through, and it impacted me, and I had a setback. And I was able to limp back home after several months driving. I reduced my exposure in my vehicle coming back. And now I'm back home after several months. My tinnitus is getting worse. Hyperacusis has gotten worse, and the dizziness is getting worse.
Wow.
So I'm outside the 80%, but Dr. Jackson recommended I get back in and do another surgery with him. And
Right.
after listening to you, can I ask one question? I'm not sure. I got to ask him if he wrapped the stapes. I'm not sure if he did or not. I have to find out, but I know he did the round and oval windows, but I'm not sure if he did the stapes, and maybe that.
Yeah. Round and oval. This oval window is the stapes. That's just the technology jargon that we use for that.
Got it. So you're recommending that.
I think you should, do what he says. I would do it.
Go for a second round.
Yeah.
Okay. Yeah, because it's like you heard from everybody else here on the seminar. It's very debilitating, very frustrating, and
Right.
Unfortunately, not enough people like you and Dr. Jackson and such who are trying to think outside the box and actually do something. There's not a lot of interest in this, so I commend you for doing
Right.
this, and thank you.
Right. Thank you. Yeah, it's been very gratifying. My partners thought I was crazy when I told them that I was going to do this. And they said I would have a psychiatric practice, a full psychiatric practice after starting this surgery. But it's just the opposite of what happened, because it seems this has been the quickest way to improve a mental problem that I know of. My father was a psychiatrist and saw patients for years and years. But this surgery, if it works, patients' attitude and emotional behavior changes dramatically.
Absolutely. I just commend one more thing. Those of us out there who have been suffering for years on this stuff, you newcomers who've just acquired hyperacusis, this is a blessing. If you're getting it now, I know it's hard, but if you're getting it now and you have an option, I'd recommend the surgery. Even though mine is at a setback, I'm probably gonna go back and get the second round. But I would also.
Yeah, go ahead.
I'd also recommend to others who are thinking it's a psychological thing, it does affect you psychologically because you isolate to get away from
Right.
sound.
Right.
But try not to do that because it's debilitating for you and your family. Do the best you can. Just keep the faith. Keep faith in God.
Right. Good. Yeah. So yeah, it's very interesting what you said, because I didn't mention this, but the patients, the few patients that did not do well said they would recommend the surgery, just like you did. I should have mentioned that, but I think we wrote about that in the paper. That patients still, even though they didn't get a result, they still recommended having it done.
How would I go about discussing this with my specialist here in Toronto? I go to Toronto General Hospital. There's a dizziness balance hearing clinic. I've been going there for about 15 years. And I know he doesn't perform this surgery. Dr. Rutka is who I see. Is there something you would recommend in terms of asking him if they would be interested in looking into it?
Yeah.
Yeah.
They could check the website out, or they could call me, or
Okay.
it's really not difficult surgery. And the reason that I've had patients come here is that I wanted the procedure to be done the same way each time on everybody, so that I could tell what the results were. And I was afraid that what would happen when the doctors start doing this, everybody's going to do it differently. And then they're going to say it doesn't work. And so I've been through all this. And so this is why I've resisted having the patients go elsewhere, because I wanted to make sure they got the same procedure that I know worked on most patients.
Is there a long waiting list to get this done with you?
No, I do it with Dr. Nyack. The two of us do it together.
Okay.
Dr. Silverstein, hello, this is Gene. I have an appointment with you guys on the 14th of this month for consultation for the surgery. I have severe hyperacusis, pain hyperacusis in both ears from a sound trauma. And I was wondering what the success rate was, if there's any difference in the success rate between pain hyperacusis and loudness hyperacusis.
No, like I told you, the pain, I'm not going to guarantee it, but I tell you that most of the patients have said the pain's going away.
Great.
And so, and I've been amazed at that. And just like I'm amazed that the other ear gets better. So there's things that happen from this surgery that I don't actually understand. I just know the result.
Wonderful. Well, appreciate it. Looking forward to meeting you guys on the 14th.
Okay.
There's a question. Can this surgery relieve the constant feeling of my ears being clogged in addition to the sensitivity of sounds?
Probably not.
Any other questions?
Hello. Yes. So I read online that you referenced Dr. Banerjee in the UK in one of your papers, and I was just wanted to ask if it's the same procedure as yours, because I noticed you were quite particular about the procedure, using the same one on every patient, and I was just wondering if it's the same procedure as yours, which he uses as well, because I was thinking, based on the proximity to myself, if I could go in for his procedure.
Yeah, it sounds like, yeah, he does the same procedure, right?
Okay, all right, thank you.
Yes. Hello. Hello, doctor. Can you hear me?
Yes, I'm here.
Okay, thank you. My name is Charmilet. I have an surgery schedule for January next year with you and Dr. Naya. And I think this is a blessing for us. But my question is, I have been hyperacousin for the last 20 years. So that one is really, really difficult for us, my family and me. My question is, you know, when we have hyperacusis, we cannot speak by phone. For example, the only thing that I can speak by phone is using a speaker. But my question is, why, if I put the telephone in my ear, even if without sounds, even if no sounds, why my ear is still pain? Why I feel pain? Maybe the cell phone emit or produce some radiation waves?
I don't know the answer to that. Sorry.
Okay, thank you.
Doctor?
Was it?
Is it radiation from the phone, she said?
No.
Okay.
No.
Okay, any other questions?
Yeah, I have a question. Besides the patient, thank you, doctor, by the way, for doing this. Besides the patient who said that she had an increase in tinnitus after the operation, are there any other side effects that a patient would have to worry about?
Yes, yes. There's a rare instance of taste being affected temporarily because that taste nerve runs right across where we're operating. So if that's touched a little bit, you may have a funny taste in your tongue, one part of your tongue for a while. That's happened only in one patient. And there's a possibility of infection, which is we haven't seen because we give antibiotics before and afterwards. There's a possibility of hearing loss. We've had some patients with a little bit of hearing loss in the higher frequencies that they haven't noticed it, but we've measured it. And it probably is a good thing rather than a bad thing. They don't notice it, and it may be affecting, making the result better. I don't know. But there's a couple of patients that have had a little bit of hearing loss for the higher tones that they don't seem to recognize. But
is there any risk of vertigo from the surgery?
No.
Okay.
Oh, well, I shouldn't say that. There's always risk in vertigo when you do surgery on the ear, but we have never seen it.
Okay.
Has anybody's hyperacusis gotten worse after a period of time? In other words, a benefit with the surgery and then?
There have been like I said, there's one patient that we're going to redo that's had, after the COVID got worse. I don't know an answer to that question. I haven't seen anybody.
What about your colleagues? Do they all support this surgery?
Yeah, they all send the patients to me to let us do it.
There's another.
I'd like to be involved in it because I've been involved in research and development since I was a young doctor. So I think they appreciate that. And, you know, I'm the expert on it. And we try to send patients to each other that we're expert in. One doctor does a lot of cochlear implants. Another doctor does a lot of sinus surgery. And that's the way it goes.
Is there a number of operations that would, let's say, make you publish this?
It's been published in 4 publications. We've published all the surgery, all the results. You can read it.
And how many operations have you done? I think you said in the beginning, what was it? 20?
We did 7. We're up to 70 now.
70.
Yeah. No, no, it's actually 85.
85.
But 85 years. And it's almost 70 patients.
70 patients.
Hello, doctor.
Yes.
Yes. You mentioned, somebody had mentioned something about an acoustic neuroma.
Right.
Now, I had an acoustic neuroma that was removed, translab surgery.
Right.
And before I had the surgery, my symptoms were fullness of the ears. And I also had hyperacusis in my left ear. And that was my AN side. So when the translab was done, of course, you know, I don't have hearing on my left side, but then I got it on my right and my right ear. So you're saying that possibly, I always thought this was a result of my acoustic neuroma. So what you're saying is I probably had this before and it didn't have anything to do with my acoustic neuroma. And that's why it went to the right ear.
Right.
Oh, Okay, I just had my, I just want to thank you so much because this has been so debilitating. And I just had my consult, was it a couple of days ago, and I'm so excited. I finally have hope for the first time since this happened. And I just want to thank you for all your work you've done in this. Thank you very much.
Thank you.
We have two
Hello,
other
doctor.
questions. I don't know.
I'm actually the patient that has an acoustic neuroma and the hyperacusis. So and my doctor told me, I went back for another MRI after 6 months and it's not growing. And the doctor told me the hyperacusis would always remain because it's there. Removing the neuroma would not remove the hyperacusis. So my question to you, if I don't remove the acoustic neuroma, would I still be able to do this surgery and possibly have this surgery to remove the hyperacusis? Because that's, out of everything, is what is so debilitating this past year.
Well, if they remove the acoustic neuroma, you may lose your hearing. And if you lose your hearing, you're not going to have the hyperacusis. The only way the hyperacusis would remain is if they preserved your hearing. And I think you could have, if you had the hearing preserved and it was still bothering you, I think you could have the surgery to have it relieved.
And could I have the surgery even if I didn't remove the acoustic neuroma? Because to your point, I would have to have that translab.
How big is the tumor?
It's a 1.7 centimeters.
And how old are you?
52.
So have you had any radiation or anything for it?
No.
And what are they're just watching it?
Just a wait and watch.
How long have you had it?
Just at a year. 11/9 was when I discovered it. Wow, today's my anniversary.
Okay, wow. If it's hard to say, like I said, we haven't done any patients with acoustic neuromas.
I'm cooking right now.
But we're willing to try something if it's if it makes sense. So
Okay.
if you're going to if the tumor is not growing and the hyperacusis is bothering you a lot, this is a minor procedure. I don't think it would be bad to try it.
Okay, thank you so much. That's very helpful.
So I was wondering, Dr. Silverstein, what happens with the tissue over the years that you place on the oval and round window? Does it dissolve or?
We think that it stays there, and we use that tissue to rebuild eardrums all the time. So we know that the tissue usually stays as fascia. And so we haven't been back in there to see that. So we'll be back in there to see somebody that we did 2 years ago soon. So we'll know.
Okay.
We'll get an idea of what happens to the tissue. We don't know that.
Interesting. Okay, thank you.
Hello, doctor.
Yes.
Yeah, my name is David. I had to step away for a second. I'm not sure if my question got answered that are in the written text here. But does your surgery also work for pain hyperacusis and not just loudness? I do have pain which goes to my middle and inner ear. It does?
Yes. We answered that question several times. Yeah.
Okay, perfect. And I'm also out in Toronto as well, and I've seen Dr. Rutka for it, and I've asked him if he's willing to learn the surgery or anything. And are there any other doctors in Canada that you know of that would perform this at all, or?
Dr. Parnes, maybe.
Dr. Parnes?
Parnes.
Okay, and where's he located in Canada?
I think he's in Toronto.
In Toronto. Okay, what's the spelling of that? Sorry, it's hard to hear you.
Parnes.
Parnes. Okay, thank you.
And his first name is Lorne.
Thank you.
What's the surgical approach?
the surgical approach is through the ear canal, lifting the eardrum. I showed that in the
Okay.
in
I'm
the
sorry.
video.
No temporal, no incision, cranial incision.
No, just incision in the ear canal, just to
Yep.
lift the eardrum up. It's like
Okay.
looking inside a book.
Got you.
Okay, there's quick questions from the chat and then we'll wrap it up. If you have depression, are you eligible for hyperacusis surgery?
Yeah.
Okay, and then the other one is there has been research about hairs in the cochlea being damaged after sound exposure. What are your thoughts on this?
That's what happens. Exactly what happens. And that's why we're doing this study where we're injecting the 322. We're injecting medications into the ear to try to regenerate these hair cells that are damaged. So we're going to have to go.
Yeah. Thank you everyone for joining, and the recording will be emailed out to everyone.
Okay. We'll see you later. Come and see us anytime you want.